very much. Sometimes it's a cliche when you say this is an exciting evening, but this is an exciting evening. For years, those of us who've been advocating for single payer have been asked, how will you pay for it? Can we afford it? What will it cost me? And we've mumbled and pointed to studies here and there, but we had nothing to say about New York when we were lobbying New York. And now we have answers. The credit for it first goes to the organizers who have created the Campaign for New York Health. The legislation that Assemblyman Gottfried and Senator Perkins are the joint sponsors of is called the New York Health Act. And the organizers single-payer organizers led, I should say, by Katie Robbins and Annette Guardino of our chapter, have created the Campaign for New York Health.org. It's a website, and that's where you'll find the study if you want to read it in full, and I hope you will. And in the course of that organizing over the last few months, they raised enough money, primarily from the unions, which have joined that coalition, to enable us to actually hire a leading economist to do this study for us. We were fortunate to get Jerry Friedman from the University of Massachusetts in Amherst to conduct the study for us in New York. Jerry has done similar studies in first of HR 676 of our national single-payer bill, and then of single-payer legislation in Maryland, Pennsylvania, and Oregon. Have study, will travel, I guess, is his slogan. I've worked with him sort of from a distance and just watching what he was doing and trying to give advice, and it's been a real pleasure. Jerry has a bachelor's degree from Columbia University and a PhD from Harvard in economics. He's been at UMass Amherst since 1984. Those of you who might know about the field of the academic field of economics might recognize that UMass Amherst is probably the most progressive economics department in the country, and Jerry is now the chair of that department. Whether he chose it or not, that happened to him at the same time as he was completing our study, but he did a fabulous job on the study, and I'm sure is doing and will do a great job as chair. So I'm very happy that he will be here to present for the first time in public, the study he did for New York. Following him, the discussant for this evening is Stephen Toft. Steve has just come to New York as a director of strategic programs for the Nurses Union, New York State Nurses Association. He's a veteran union organizer in campaigns across the country. He's very modest in his academic credentials. He holds degrees, he says, in labor studies, political economy, and law, but will not tell me what they are. So he is an organizer and will respond to Jerry's presentation with what are some views from the union movement, and as an organizer, how can we use this study to advance our cause. So I'm very, very excited to welcome Jerry Friedman to present.
Thank you, Len. Len was too modest in saying he made some suggestions from afar. I've done these studies for 6 states and the federal HR 676. And between Len and Dick Gottfried, I got the best feedback, and I learned the most. Which is really, honestly, that's what it's all about, the academics. You want to do something useful politically, but personally, yeah, I learned some things here, and that was great. Also, I got to come back to New York. If you can't tell from my accent, I was born here. I grew up here, and honestly, honestly, you know, when John Updike talks about people from New York that say you're from someplace else, you're only kidding. My family, that's it. They always say to me at Thanksgiving, Jerry, are you still living in Massachusetts? You know, it's like, I'm tenured. Tenured is like tethered. I can't move. But I do love Amherst. Thank you. I love Massachusetts, the Bay State, home of abolition, and we're still hoping that we will be the first to have single payer. But you know, with Dick Gottfried and Len and all of you here, New York may win. So, you know, I'm not betting, not putting down any money. Also, just as a side note, you know, I'll tell Steve that my first 2 monograph books were on labor history. So, you know, political economy, labor history, you know, we should talk. Okay, enough of that. Economic analysis, New York Health Act. One thing you won't hear from me are the words human rights. This is dollars and cents. I see my role in this movement as, okay, I'm happy to talk to you, but what I really want to do is talk to the board of Fortune 500 companies and talk to chambers of commerce. Because what we have here is, regardless of how you feel about your neighbors and people down the street, whatever, you want to make more money. And that's what this analysis comes to. If you want more money in your pockets, then stop giving it to the health insurance industry and the drug monopolists. So this is a dollars and cents proposition. Okay. Oh yes, one of my favorite cartoons. Big insurance, we found the problem. Okay, here's where you've been, and here's where you're going in New York. The blue line is an index of healthcare spending. The red line is an index of per capita income in the state. The average income, if you took all the income, all the money generated in the state divided by the population, and indexed it to 2000, well actually to 1990, this is your income. And here's your healthcare spending. You've got a problem. I forget who it was. Herb Stein, the economist, I think, said, if something can't go on forever, it will eventually stop. We haven't reached that point yet, you know, but there's your healthcare spending. Eventually, you're going to run out of money. In fact, if you look at the Congressional Budget Office long-term budget outlook, and I haven't done this for 2 years, but you can download their spreadsheets, and you'll look and see that they have their projections of healthcare spending for the whole United States and income, and by 2062, healthcare spending will equal 100% of income. Now, I often say economists aren't popular because we're not funny, and which is very much true. But we do have a couple of jokes, and that's one of them. Because the Congressional Budget Office then has another 15 years of projections, where healthcare spending is greater and greater and greater than income. It's like, what are we living on? Air? You know, okay, anyway, that's where you go in New York State. Eventually, this is why you will get single payer eventually. Because there's not going to be any alternative. There's no other way to control healthcare spending, I guess, except by killing people or something. But, you know, so maybe shouldn't do too much. Okay, anyway, now it wouldn't be so bad. You know, there are a lot of things we spend more and more money on. It wouldn't be so bad. We're getting a worse and worse healthcare system. Now, when I was in graduate school, I was studying slavery, then I studied labor, but along the way I went to a seminar, and one day Richard Zuckerman came in, who was head of the Kennedy School at the time. He had been one of the original sponsors of health maintenance organizations when he worked for Richard Nixon. Then he worked for Jimmy Carter, and he worked for Bill Clinton, you know, bipartisan. Okay, anyway, Zuckerman got up, said, okay, healthcare spending is a waste. because there's no increase in life expectancy associated with increased healthcare spending. Therefore, we can reduce healthcare spending without hurting anybody. Very popular attitude among economists. And it's based on the US experience, because in the US, we spend more and more and more on healthcare, and we are not getting greater longevity or better health outcomes. On the other hand, every other country in the OECD, each diamond here represents a country in the Organization of Economic Cooperation and Development, the club of the rich. And here's their per capita healthcare spending, and here's the life expectancy. Look at this. It's upward sloping, it bends actually. And this is what you get in other countries, with every one of these countries has some form of universal healthcare. Single payer in Canada, National Health Service in Britain, multiple but very regulated in Germany. And all of these countries does better than the United States. In fact, if you do the regression here, you'll get the United States, for the spending we have, we should have life expectancy of 83 years. Or 84 years. Or you could say for the life expectancy we actually have, we should only spend $2,000 per person. Now I like to ask people, which would you rather get? 5 more years of life or $6,000 back? The young people in the audience, I can see some medical students and all, and Katie, they might choose the money. I'm old enough, since I've been doing single payer and working on graphs like this, I passed the point. Now I want the years. Okay. So, Larry Summers, we called him Attila the Hun in graduate school. But he was always fun. It was said in jest. Later it became serious. Anyway, Larry Summers is one of those who says Americans don't buy health care on the margin because of insurance. Therefore, and he said this to me once, it was 30 years ago, he wouldn't remember, but that's okay, I remember. He said to me, if something is free, you'll use too much of it. Well, technically it's not free, we have co-pays, whatever, thank you Larry, and thank you economists. But this is the basic argument, that we use too much health care because we have insurance and we don't pay for it. Except we don't. We use less health care than everybody else. Here again, when I was in graduate school, the OECD was the club of the rich. It came out of the Marshall Plan. It was West Europe, the United States. Then we started, for political reasons, letting in the riffraff, like Mexico, and no offense intended. And that distorts the statistics. So for here, I threw out the poor countries. But it actually doesn't matter. The non-affluent countries, like Mexico and Turkey, they still go to the doctor more than we do. Everybody goes to the doctor more than we do. Why do we die young compared to the Japanese who are up here? Well, maybe because we don't use health services. We pay for them, but we're not using them. And that's why we could save a lot of money with single payer. Because we're paying for health, but we're not getting the services. 30% of Americans experience difficulty accessing the healthcare system. I have this broken down. This is from the Commonwealth Fund. I have this broken down someplace else. About a quarter of Americans report they did not fill a prescription because of cost. Think about that. You went to a doctor who told you, you know what? You should take this. You should take amoxicillin. You should take this, whatever it is. And you walk out, and having gone to the doctor because you're sick, having been confirmed to be sick, the doctor considers you sick and has something to help you, but no, you toss it in the wastebasket because you can't afford it. Are we surprised that people die from things like this? And that we have Americans are sick more often, about twice as often as people in Britain? We get less health care because we prevent people from using it by rationing it by cost. This is the response to people like Summers. I don't mean to pick on Larry. I actually like him. He's kind of fun. He's like my older brother.
But this is the attitude that economists have brought to healthcare for 40 years, that we use too much of it, we need to restrict access. And we are doing it. We're doing it very well. We're doing it better and better, and the price we're paying is death. Each diamond here, it looks like a blob, but actually each of these is a diamond. Over 3,000 counties, every county in the United States. The proportion of people with cost-related access problems, which actually the question is, did you not go to the doctor because of cost in the past year? It ranges from a little more than 3% all the way up to some counties, I believe in West Virginia and Kentucky. This is pre-ACA, so Kentucky maybe is doing better now. Can't vouch for West Virginia. Over 40% of the population said they did not go to the doctor in the past year because of cost. Look what happens. Here is age-adjusted mortality. Why are we surprised? Only economists would be surprised. When people don't get health care, they die. New York State, a similar graph, similar regression line. I project if we lowered the rate that are not able to go to the doctor to 4% in every county in New York State, there'd be 14,000 fewer deaths each year. That is the price of restricting access to health care. It gets worse. It's like economists, okay, we have bad sense of humor, also the dismal science. Look at this one. This is really dismal because you would think it's dismal because of the results. I think it's dismal because I looked at the data, but I didn't break it out by gender, so I missed the big point. I looked at these same data. This is a study by Bosworth and somebody else, the Brookings. Social Security Administration data. And they have people's income. That is what they paid Social Security, the income they paid Social Security tax on. And they know for people, how long they lived. Some of these people born in 1920 are still alive, but you can project their life expectancy. So the blue line shows for each income group, males born in 1920, how much longer they lived after age 55. So the richest lived another 30 years. They lived to 85. The poorest lived only 23 years. Now you go 20 years later, you look at the older cohort, the richest live a lot longer. They live like 6 years longer than their parents did. The poorest hardly live longer at all. The gradient of income and life expectancy has increased, has become steeper in the United States for men. But at least, by the way, the rest of the OECD, they've gained on average 4 years. So the richest Americans are doing the richest American men are doing a little bit better than the average, and the poorest American men, including middle class, lower middle class, are doing worse than the average for the OECD. But at least men are living longer. Look at women. 40% of American women now have shorter life expectancies than their mothers did. What an indictment of neoliberal economic policies. Repealing AFDC, cutting back on access to health care, raising co-pays, raising deductibles. The first time I presented this, I'm telling you what an idiot I am. The first time I presented this, I said, I don't understand what could have happened. What could be going on for poor American women? Somebody who worked at a food bank came up to me, and I should have known, not because but I read Zola, Germinal. Who doesn't eat when they're running out of money? Mom. Who doesn't fill prescriptions? Mom. This shows up. I just did a thing. Among Len's accomplishments, he was one of the original sponsors of the journal, the popular magazine, economics magazine, Dollars and Cents, where I read a column every 2 months. I just did one on food insecurity. 30% of households with suffering food insecurity, an adult did not eat one day in the past month. Only 2% of households, a child did not eat at all. Of course not. You're not gonna eat if your children can't eat. You're not gonna fill a prescription for yourself if you can't do it for your children. And who's not gonna fill the prescription? Mom. And then mom dies. Yeah. And that's what's going on. For the poorer 40% of American women, these are women who are single moms, who have the worst jobs, the lowest income. These are the ones suffering from cutbacks and social programs, and these are the ones who can't afford prescriptions for themselves. For their children, they do whatever they can. Okay, so we're rationing by income. You could say, okay, you could say we're spending too much money, but at least we're getting health care. No, we're not. You could say we're rationing, but at least we're controlling costs. No, of course we're not. Costs are rising faster in the United States than in any other country. Canada and the United States, we spent almost the same amount of GDP on healthcare in 1971 when they started Medicare. You know why they call it Medicare? Just to laugh at us. Their single payer plan is called Medicare. They say, oh, south of the border, you've got something called Medicare, not like ours. We got the real thing. Okay, okay, here it is. What's been going on? Why are costs rising? Prescription drug prices are out of control. If you have hepatitis C, you know about this. Gilead Scientific made $13 billion last year, which was more than they spent on R&D for the previous decade on one drug. They also made some money on that drug in foreign countries, but they don't tell you how much because they didn't make very much. The National Health Service negotiated prices for Sovital or something like that, that are way lower than what we pay here. We pay $85,000 for a treatment. You know, they're paying $10,000. Yeah. Okay. Prescription drugs and the administration of private healthcare system. These are the things that are driving up the costs. I could add to this billing and insurance-related activities in provider offices and hospitals. Back in the mid-1990s, Massachusetts General Hospital had 250 people doing billing. Toronto General, about the same size, 2. And one of them was devoted to billing people from the United States. Okay, so I said this, you know, at the Massachusetts State House a couple years ago, and I said this is from the 1990s. A woman came up to me, a legislator, and said her husband was in management at Mass General. You know how many people they have doing billing as of like 2010? 450.
Right.
Yeah. They had not significantly increased the number of hospital beds or doctors at Mass General as against the whole partner system, but they had almost doubled the number of people doing billing. Because the insurance industry not only drives up its own costs, but they pass those costs onto your practices or your doctor's practices. Administrative bloat is no accident. You know, this is not something that just happens. It happens because insurance companies make money by denying access. My father was in the coffee business. I'm a socialist, or worse, but if I was talking to a Chamber of Commerce group, I'd say I'm the child of a businessman, and my brothers are in business, and I appreciate business. I appreciate that Kensington, the company that made the Zappa, if you ever need a Zappa, this is the Zappa. I give this to every graduate student whose dissertation I sign. This is what you start out in life, in academic life, a good Zappa. And Kensington has an incentive to make a good Zappa because they make more money. Insurance companies are different. United Healthcare makes money by finding the people who are going to be expensive, the people who are going to get sick, and getting rid of them. Find the 10% who are going to account for most of your medical losses. That's what they call it. The money they pay of our premiums that goes to our healthcare is a medical loss to them. Find those people, drive them out. Pick the cherries. You know, the cherries are the young people over there. Drop the lemons, the guys like me. Yeah. Find the people who are going to get sick and get them to go away. One way you get them to go away is you make the billing and the billing process so onerous and difficult. Which means you're inflating the administrative costs, but that's nothing to you. The main point is to get those people to find another insurance company. The New York Health Act, I confessed, I'm a socialist, or worse. I would like a national health service. I think the British got it right. But that's not the New York Health Act. To me, the New York Health Act is a compromise. It's not like the ACA. I used to teach at Harvard with Zeke Emanuel, social theory. I learned a lot from Zeke. He's a very smart guy. And even then, he was way ready to compromise on all sorts of things. Okay, different approaches. My compromise is single payer. Public funding, private delivery. We're not touching what goes on between patients and the doctors. You go to choose your doctor chooses his or her patients. All that doesn't change. All that changes is the way we fund it. Instead of people buying private health insurance as a lump sum tax, which, by the way, a poll tax would be banned by the 24th Amendment to the Constitution, but we kept it for health care. Everybody pays the same amount for health care. Chris, the department secretary, pays the same health insurance bill that I pay, or that my colleagues who earn more than me pay. Everybody pays the same amount, except if you're sick, and then you pay even more because you have to pay for the co-pays and deductibles, etc. We'll replace that with a system where everybody's covered, no penalty on the sick. It's bad enough you're sick, then you have to pay $45 for a specialist, $30 for the prescription, on and on. Okay, everyone's covered, everything's covered, no deductibles, no co-pays, and it's all financed through something, assessments related to your ability to pay. If you're low income, if you earn less than $25,000, if you don't have much capital gains or any of that stuff, you're out. You don't pay anything. As you move up the ladder, you pay more because you can afford to. Okay. One way we can do this is by saving $71 billion. Yes, that's billion with a B. Yeah. A quarter of New York State's, what I project to be New York State's healthcare spending in 2019. We could provide in 2019 the exact same mix of services at a price 25% lower. That's the message you could take to the Chamber of Commerce. Because whether it's businesses or individuals, it's people in New York State who are paying that money. Some of it goes to reducing billing and insurance-related activities in doctors' offices to the level of Canada. Some of it goes to eliminating most of the cost of administering health insurance. I mean, some is left. I assume we'll operate the New York Health Plan at the level of efficiency of Medicare, fee-for-service, traditional Medicare. So you still have to pay something to operate the system, but a lot less, basically 1/10 as much. Some of it comes from saving employers directly $2 billion that New York State employers spend finding an insurance company, negotiating with an insurance company, and processing paper for the insurance company. Mind you, I'm not including here the savings to individuals from processing paper to get reimbursed from insurance companies. That's a further saving that's not included here. Some of it is from reduced fraud because single payer system will make it really easy to prevent double billing. My mother-in-law is 90 on Medicare, her retiree health plan, and her husband's retiree. My wife looks at the bills, explanation of benefits. Can anybody figure these out? I mean, I have a PhD. My wife is highly educated. My mother-in-law has a PhD from Cornell in literature. Nobody can figure these things out. I mean, I tried putting them on spreadsheets, matching. It's like, oh, forget it. Who knows who's paying what? And $16 billion from reducing monopoly profits, or reducing some monopoly profits. on drugs and medical devices. This just comes from lowering prices, negotiating prices for drugs and medical devices to the level of the world average as of 8 years ago. The world average is probably lower relative to the United States now. This is probably an underestimate of the savings we could capture here. By the way, the Veterans Administration does this. They negotiate drug prices, and they pay 41% less than the rest of us. I'm assuming we'd pay 37% less than we're paying now. New York State's a huge market. It's the size of a small European country, small to mid-sized European countries. It could negotiate prices that would be, like what they pay in Italy. If I had time, I'd tell you about when my daughter got sick in Florence, and we bought drugs and went to the hospital, walked out, my wife waving her credit card. And the doctor saying, chow, chow. Finally, she found a nurse speaking English, and the nurse said, Italian hospital, no pay, not like America. I got to the pharmacy. I turned around looking for magazines. By the time I came back, by the time I realized they didn't sell magazines at pharmacies in Italy, the pharmacist was done. That's why they don't sell magazines. They don't wait around to deal with insurance. And then the price, I actually took those prescriptions to CVS when we got home. They were 25% in Italy, what I would have paid in the United States for Z-Pak and a pain med thing. Yeah. Okay. By removing cost sharing, New York will have real universal access. A lot of people focus on people who don't have health insurance, which getting everybody health insurance is a really good thing. But the majority, 3/4 of the people I identify as dying unnecessarily because they did not have access to health care in New York State had health insurance or have health insurance. Health insurance is a step towards access, but it is by no means a guarantee of access. You could have a deductible of $1,000, $1,700. I believe $1,700 is about the average for New York State employer family plans now. $1,700, that makes you think twice, 3 times, 4 times about going to the doctor, about filling prescriptions. People without health insurance, yes, they have access problems, so do people with health insurance. Removing cost sharing will allow real universal access. That's going to cost money. First of all, it's going to cost $4 billion just to cover the uninsured. This is after the ACA. Keep in mind, the ACA will lower the number of people without health insurance by about half. There'll still be 1.3 million New Yorkers without health insurance, including 300,000 undocumented immigrants and 1 million other people who just fall through the cracks, whatever. So that's going to cost $4 billion. It's going to cost $10 billion to raise Medicare and Medicaid fees to levels where doctors will accept New York plan. All doctors. About half of doctors do not accept Medicaid. A great many doctors do not, I think more on the order of 15%, but growing, do not accept Medicare. It varies by specialty. I confess, my beloved oldest sister stopped accepting Medicare reimbursements as she was a psychologist, and just the rates were too low. It wasn't worth her time to go into the office. Then we have, then there's $11 billion for increased utilization, because you do away with the co-pays and deductibles and people start going to the doctor more, and that costs money. Yeah. I mean, this is where we save people's lives. So these are costs, but they're also benefits. With $15 billion spent here, we save 14,000 lives worth, I'm an economist, I warned you, $55 billion. And then $290 million to cover 2 years of unemployment insurance and job retraining for people displaced from the health insurance industry and from Europe, from billing and insurance-related activities. Okay, we cover everyone while saving money. These are the extra costs. come to $26 billion. Here are the savings, come to $71 billion. I will not embarrass anybody by calling on you, which I would do in my microeconomics class, and asking you if you can subtract 26 from 71. I'm sure this group, everybody can. And you get 45 billion net savings. So after we've done these things that make life better for people, we still have $45 billion left over to spend on getting another boat, getting an extra week of skiing in northern Vermont, or whatever it is you want to do. Paying off your grad school loans, I don't know, buying another poodle, whatever. Okay, everyone will have real insurance. This is the number of people who will gain access. 1.3 million who are currently uninsured, and another 1.3 million who are already insured, but reported that they could not go to a doctor because of cost. So 2.6 million people will be able to go to the doctor who could not now. We're removing the penalty from being sick or disabled. Life is hard enough when, you woke up or your kids woke up and they had, they felt so bad and everything. And then you have to decide, is it worth $35 to go to the doctor? What? It's just, I said I wouldn't use the words human rights, but I'll say it is inhumane. And it often leads to economically expensive debt. Okay, shift spending towards health care. We'll actually be spending more on actual health care. By the way, this is a mistake. This is an early version. This number should be like $200 billion that we'll be spending on actual health care delivery. Doctors, drugs, etc. We'll spend more under the New York Health Act, which is where we're providing coverage for the people who don't have it now, and where we're saving lives because we're having more health care. It's just all the other stuff that we're cutting down. I have 16 billion monopoly profits for the drugs, and the device manufacturers will be reducing insurance administration. We'll be cutting back on what hospitals and doctors have to pay for billing insurance-related activities. So we're cutting down on all the stuff we don't like so that we have more money for actual care. And we're doing it while 98% of New Yorkers will be saving money. You'll be getting better health care and you'll be saving money. It's like walking out on the street and seeing $20 sitting there. Another economist joke is George Stigler, Nobel Prize winner from Chicago, was walking on the street with a grad student. The grad student saw $20 on the street and said, "Oh, I'm going to go get that money." And Stigler said, "Nah, don't bother. If it were real, somebody would have picked it up already." Well, there are $45 billion sitting out there on the street waiting for us to pick it up. And the biggest benefits will go to middle-class working New Yorkers. The poorest New Yorkers already have Medicaid, although it will be a lot better if the doctor is being reimbursed properly, and they have ACA subsidies, which is actually, to defend the Obama administration of Larry Summers, the biggest income redistribution program enacted in the United States, period. These people will gain some, but it's the working people who will gain the most, because we will be replacing their expensive private health insurance with a relatively inexpensive assessment on their wages and salaries, an assessment that is really quite small, because the first $25,000 isn't assessed at all. So it's only, if you're earning $35,000, you're paying an assessment on $10,000 of income, and at a lower rate because this is a progressive assessment. So these people, working people, really make out the best. And 98% of New Yorkers will save money. This is not just, something for, low-income workers. It's not just something for middle-income workers. This goes up to beyond college professors. I mean, even Paul Krugman, with his big contract at CUNY, will be saving money, just barely. And that's not count, actually, forget, I take that back, because that's not counting his speaking fees. Oh, I don't have time to tell you that story. Okay. Average workers will save, especially their children. This is a plan to help children and caregivers. Caregivers, parents who stay home with their children, daughters who take care of elderly parents and therefore can't hold down paying jobs, they pay nothing, no assessment, because there's no payroll. But they get health care. And their children, those moochers, the 47% who, God, they just take from the public school system and discount bus fares, etc. Children, they'll get free health care. Good health care. Businesses will save money. The payroll assessment will be 8%, averages 8% of payroll, instead of over 10% that businesses pay now. Businesses are going to walk away saving $2 billion off the top by not having to deal with the insurance industry. Businesses won't have to worry about it. Small businesses will be the biggest beneficiaries, because small businesses are the ones subject to the biggest variation in health, the highest health insurance premiums, and the biggest variation. If somebody tells you, oh God, my brother's restaurant will really hurt under the New York Health Act, bull. The brother's restaurant will have insured healthy workers at a minimal cost to the business, instead of the expensive private health insurance plan that they would have had. And they won't have to worry about it. I have friends who run businesses in Amherst. I told you I was a small businessman. Actually, I'm an investor. I have a share in a bookstore. So I am a small businessman. And businesses, small businesses especially, but large businesses, all businesses worry about health care. It diverts them from thinking about how to do a better job making better zappers. Okay. Entrepreneurial energies. Your daughter wants to start a yoga studio? She won't have to think about, how will I get health insurance? Well, she's still on my plan, but only for another 2 years. Eliminates legacy costs. My mother-in-law's health insurance from Norton, I'm sure they didn't prepay for that health insurance for retirees. Almost nobody did. Governments in New York State have tens of billions of dollars of costs for retiree health plans that are not funded. Unfunded liabilities. These are sitting like a time bomb, and that's waiting every time any of you goes into negotiations with government on behalf of your public employee union. One of the first things they're going to say to you is, oh, well, we have to spend all this on retiree health care costs. That's why we have to lower your wages. Well, those go away. Lowest burden of property taxes. We'll be picking up $13 billion in 2019, currently paid by local governments, because the New York Health Plan will assume all Medicaid costs, and it will save local governments $6 billion in the cost of health insurance premiums. And we have 200,000 new jobs. That's my projection, because New York will be a good place. It's a good place to do business. It's a great place to do business. It's really the only place to do business. It's the only place to live, unless you're lucky enough to live in Cambridge, Massachusetts, or Amherst. Well, okay, Berkeley. Maybe Madison. No, not Madison anymore. But New York will have 200,000 new jobs, because costs of doing business will be less. New York businesses will be able to undersell their competitors in Chris Christie's, New Jersey, and they'll be able, and businesses from Connecticut will move to New York because they can take advantage of the lower cost of doing business. We'll save lives, 14,000 lives, 5,000 Republicans upstate, 6,000 New York City people. 2,700 in the purple urban counties upstate, I don't know. And then 225 in Nassau, Suffolk, Westchester, Putnam, and Orange. As I said, economic value 55 billion if you want to be really crass about it. New York Health Act is sustainable. It will control costs going forward. Remember that scary graph? Rise in costs? Not anymore. It will actually bring, oh sorry, wrong way. The New York Health Act will not only lower the share of healthcare spending out of state GDP back to the level of 2000, reversing 10 years, 15 years of growth, but it will then control costs, because remember the things that were rising fastest? Administration and drug prices? Those are the two things we're really going after. Control those, you control healthcare spending growth. That's what the Canadians do, that's what the Europeans do. It works for them, and it can work here. It's only going to happen if you do something. We're up against a power as great as the slavocracy of the 1850s. The insurance industry and the drug companies are among the most profitable, most politically wired industries in the country. That's why the Obama administration backed away from taking them on. But the result is we still have the problems. And we won't solve them until everybody gets out there protesting and demanding change. And thank you very much.
Well, I'll do my best to follow up on that, but I do, the degree I have in, my modest degrees that I didn't tell them what they were, I studied economics at the University of Campinas in Brazil. There's a very heterodox progressive economics program there. It was part of a program that taught economics to trade unionists. It's a master's degree for trade unionists to understand how economics are shaping a lot of the work that we do in the labor movement. What's interesting for me, and I'll get to the report in a sec, because it was for trade unionists from all over the world, not just from Brazil, but from Africa, from Europe. And the focus of so much of the program for us as trade unionists was to understand how public policy and how economic policy shapes our lives as trade unionists. And I felt like I was coming into this program with an incredible disadvantage compared to a lot of the other trade unions that immediately understood the relationship between their labor union and the economics of their bargaining. Because we have a very different system of collective bargaining in the United States than they have in most of the world. And we also don't have the same kind of social welfare system they have in most of the world, where they have things like single-payer health care. And because we don't have those things, because the labor movements in the United States have traditionally fought for their members and their members only, and they've done a very good job, well, they did a very good job for a number of years of providing things for their members, which did raise the standard of living for other working people. But it wasn't truly a movement for working people. It was, and that, you know, the labor movement gets a lot of heat for this, and I give them heat for it too, but it's not entirely their fault. It's the way that the system was designed, as I later found out when I started studying law. I don't know why. So I'll speak to this just very briefly, some of our responses. You know, the New York State Nurses Association has been a strong advocate of single payer since long before I got there. But part of why they brought me on was that they wanted to build a real campaign and work with the partners like PNHP to change the shape of the discussion in New York and nationally. Labor unions like the New York State Nurses Association, you know, nurses are unique because they work in healthcare, just like doctors, but we're still a union. And one of the challenges that we've run into in the labor movement is that for so long we've been wed to this process of reasons to be a member of a labor union in this country. You know, if you ask people why they pay their dues, they often think that, well, I pay my dues and in return I get great health care. You know, I'm an iron worker, or I'm a nurse, and you know, our contracts have good benefits in them for our membership, and that's come at the expense of collective bargaining over the course of 30 or 40 years. if the state all of a sudden provided it, it would throw a big wrench in the way that that works. I think it's a good wrench ultimately, but it creates a lot of transitional problems from kind of our path dependency. What I did was, while you were speaking, I made some notes and some questions that I have for myself. I guess I'll just kind of say a few of them, then you can respond to those, and then the room, I'm sure, has many questions as well. On the issue of labor unions and our collective bargaining agreements, the way that the math breaks down, I think the assessment that individuals will pay, and it's progressive, so it goes up more and more depending on your income, but it was 80-20, that the employer picks up 80% and the employee picks up 20%. Now, in most unionized workplaces, in all the places where we represent nurses, we have the employer pay 100%. But those costs are real, even if our members don't know how much they are. It could be, $1,000, $1,500 a month for family, and those costs are being spent right now by the employer. So one of the questions that has come up time and again is when we talk about it in a blanket way, it says that, 80% of the costs are going to be borne by the employer. If you're making, $100,000 a year, then you're going to pick up 20% of the costs, but that figure is going to be less than what you're currently paying for healthcare. Well, when I tell that to a nurse, they look at me and say, I currently spend nothing on healthcare. But they don't. They're just not spending it directly. It's coming as part of the collective bargaining wage package that we get from employers, but it's a hidden cost that a lot of working people and union members don't understand how much of their weighted average wage is actually being diverted into healthcare costs. And that's not just discussing scenarios where you have a Taft-Hartley plan or unions maintain their own health funds. So I'm wondering if there's a way to break that down where we can actually see what the actual healthcare cost would be, and we would assume, and what I tell our members when I talk about this is that 20%, we've already through years of negotiation convinced the employers to pay, $1,500, $2,000 a month per employee into a healthcare fund. We will expect them to continue to pay that same amount. And if it's less to insure the total package now, then they can pick up that 20%. Because to be very clear, the New York Health Act provides for that 20% to be negotiated through a collective process. Or, it doesn't have to be a union. You could work somewhere and you could, individually strike a deal with your employer. I want you to pick up the 20%. Obviously, we believe, as a trade unionist, that we've got more power when we do it collectively. So that was one issue that I highlighted as you were speaking. The other question I have, and I think maybe other people in the room are probably concerned about this as well, but there's this long-standing debate about where do we do this nationally or do we do this state by state? I think everybody would love to have a national plan, but the politics of it has been a lot more difficult to accomplish than changing the face of politics in New York. But assuming we're successful in New York of actually implementing this plan, what is the impact on, the projected cost, one of the last slides there where it went down? I'm just imagining, people coming over for prescription drugs in New York the way that we go to Canada today. And setting aside some of the bigger questions of people, retiring in Florida and all that stuff, that can be worked out later, because I think what we're really talking about is a way to fix the problem for 98% of New Yorkers. But is it possible to project out those kinds of economics? How do we, if we're negotiating these things and we've got a great system in New York, I guess the plan is that other states are going to see this and they're going to do the same thing and that will follow. But it's come up because New York, as much as we'd like to think we are on an island, at least in Manhattan, we don't exist in a vacuum. I think the other issue as a trade unionist, not so much as the nurses union, that I think would be interesting to discuss a little more would be the question of the 200,000 jobs that will be created. I don't know, despite studying economics for a few years, how we project that. Where does that number come from? Because I saw in some of the press that came out today on the report, most of it was positive and surprised by the numbers, and they were, aggressively printing these things. But there was one report that was very much questioning how we get 200,000 jobs, and what does it look like? Because I actually would think that the number might be even higher, but it's not anything that's so tangible. If you take away the costs of employers having to deal with paying for health care, they can put those energies elsewhere. They can hire more people. They can have that entrepreneurial freedom or energies, as you put it. But even more so, the competitiveness. I mean, a lot of the trade union movement has struggled because even as we've been able to hold on to the health plans that we have, it comes at an enormous cost. The employers in the building trades are far less competitive with a non-union employer that doesn't have to pay those costs. If you think about, or the same conversation kind of took place with the UAW when the bailout was happening. And the costs of, I think the figures, maybe you remember, of how much of every car you buy is going towards, UAW healthcare. Then people get angry, like, well, why are we spending so much on their healthcare? Like, well, why does everybody not have that healthcare? But I think breaking down where that job growth actually comes from, and if it might be a higher number, but maybe the 200,000 is something that we can actually point to, is going to be one of the critiques that we're going to continue to hear. And then I was just curious, when we broke down where the money comes from, where we're wasting money in the current system with private insurance companies. I know private insurance companies also give quite a bit of money to the political process. And I wasn't sure if that just comes out, is that coming out of their profits? Their profits are after their political contributions to continue to fight campaigns like ours. But, or maybe it's just a blip in the map overall. But those were the notes that I made while you were speaking. I found it incredibly informative. We're very excited that this report exists. And NISDA is very much looking forward to continuing this fight as partners with PNHP and the Healthcare Now, Single Payer New York, and many other allies here. I think that we're changing the debate we're changing the nature of the debate in New York, and we're definitely changing the nature of the debate nationally as well. So all eyes are on New York. And
Great. I think maybe Jerry could just stand up here because the questions are clearly going to be for him. Maybe you want to respond first to some of the things, Steve.
Yeah, about the employment numbers, first of all, basically I estimate the decline in payroll costs as a share of total cost of doing business. Wages being about 45% of the cost of doing business, and decline in payroll costs as a share of that. And then I applied an elasticity of demand, commonly used in international trade, divided it by half to be conservative. And I added to that, assuming an elasticity of substitution of capital for labor of 0.4, which is a commonly used number. That's kind of like maybe like over there, but there is a basis for the number, which is the point. The 200,000, by the way, is not including increased jobs in healthcare. There are also another 50,000 jobs added in healthcare because that $15 billion in increased spending on healthcare services. Much of that is going to provide a doctor, physician, and hospitals. I'm not counting the drug process. So that's going to be creating more jobs for nurses, whatever. By the way, the National Nurses United, New York State Nurses, absolutely my favorite union. I have a colleague, Bob Poland, who you may know for his work on climate change, but also on the Tobin tax, or the financial transactions tax. And Steve, this morning, was at a conference in Washington on the Robin Hood tax, which is the Tobin tax. And so Bob and I go around talking about how much we love the nurses union, for good reason. Also, because the nurses union are in campaigning for this, they're getting ahead of the curve. Yes, and you could read my first book, State Making and Labor Movements on the United States and France, 1876 1914, where I talked about the use of benefit funds as a way of attracting members to unions. And Nelson Lichtenstein and others talking about the golden age, 47 to 75, talk about the involvement of unions in health insurance and other benefits. I mean, I studied with Richard Freeman and James Medoff when they were doing what do unions do. Benefits are a big part of it. But that's the past. Unions have to get ahead of the curve. If you go to collective bargaining negotiations these days, it's always the first thing the employers talk about is how health care costs for retirees or for current employees are too great, so we can't give you wage increases. At this point, we got to get healthcare off the bargaining table. It's working against unions. And as you say, it makes unionized workers look like there's something wrong. You're the spoiled brat with all that good health care. Cadillac, health care plans. So this is something that, it's not helping anymore. So I think unions really will benefit from getting rid of health care costs and, a single payer. You had another point. Your first point was about, the 2080. Yeah, well, Len has worked, got ahead of me. He worked out the numbers for how much it will be at different levels. If it's 20% by the employee on 9% of income, 25 to 50,000 of payroll income, and you can work out those numbers. And there's a handout with that. If you're actually, if your employee is paying 100%, which by the way at this point that's unusual, you're doing very well. But if your employee is paying 100%, you're still paying co-pays, you're still paying deductibles. And the amount, the assessment on workers at $45,000 a year income, or nurses maybe $70,000. But the assessment that they'll be paying is not all that great when it's 20% of what the assessment rate is in this progressive structure. And even without renegotiation of the contract, they will be getting savings from not paying co-pays and deductibles. So on net, I think even the well-positioned workers in collective bargaining will probably be doing better. And then, of course, you go in and you tell the employer you're saving all this money. You got to pick up, some of that. Okay, I think those are the questions.
Okay, let me just point out to people that the tax plan that's described, that Jerry's described, and that's in the handout going around, he developed this. It is not in the legislation. So there are alternative plans that we could come up with. They might be more progressive or less. I can't quite imagine one more progressive than what you have. But,
well, we could add a Tobin tax.
Yeah. But for instance, the exclusion of people earning under $25,000 from paying anything is not in the legislation, but is in the tax plan that Jerry came up with. I personally oppose it because I think everybody should be in. So everybody should contribute something, in my personal view. But even if a small amount. Okay, let's open up. You.
Me?
Yep.
Okay, so I don't know, you said in the beginning that some of them were pre-ACA figures, and some of them are after, I guess. But,
The number of uninsured.
Which figure?
in the beginning, this is before.
Okay, the number of uninsured people is after the ACA.
Okay, well, at any rate, I guess my question is, were you able to figure out, how much we would save, because there are a lot of religious organizations that are fighting to not have to cover preventative care, like contraception and things like that. If they are able to, when we would save even more if we took that burden off their plate. So I don't know how much there is being spent on, they're hiring lots of lawyers, and how much these women will be having to pay out of pocket for things like contraception at Fordham or Hobby Lobby or whatever, I don't know.
Well, the lawyers come from the administrative activities that we would be slashing. And thank heavens for that. Both my brothers got law degrees, but The basis of my estimates are Center for Medicare and Medicaid Statistics, distribution of healthcare spending by activity, which would include contraceptive activity or whatever, regardless of who's paying for it. So all that's already included. Yeah.
I'm wondering if there's, anyone thought about when they have the assessment based on income, how about putting something into it based on a lifestyle too? I mean, I work in Springfield, Mass, and so, yeah, so, but I'm from New York, but I work in Springfield, and the same pay, and it's an inner city type situation, over and over and over and over, COPD, go out and smoke, COPD, go out and smoke, I mean, there's gotta be some input from the patients as well.
Oh, you would like
And they
to.
have primary care, because they have Mass Health.
Yeah,
They
yeah,
have
you would
to.
like to.
Yeah.
I'm not assuming any savings from that, but I believe there would be savings because we'd have continuity of care.
Yeah.
We'd have opportunities for, low-income people to go. I mean, they have Mass Health in Massachusetts. And, many of them have access here as well, but many don't. And it has been shown that primary care saves money because it's primary care physicians who help people with lifestyle changes that promote health. That's one of the ways it happens. And we would be giving people access to primary care. So without directly assuming any savings here, I think there would be savings increasing over time.
David?
Dr. Friedman, I think the elephant in the room is we need to know your opinion and viewpoint on what happened in Vermont recently. So, some of us.
Oh, I'm happy to talk about that. Yeah, I mean, the first thing to note is that the Green Mountain Care Board, I applied for a position on it, and I was turned down, so, okay. The reason, is technically I'm out of state, even though I do own property in Vermont, just, we have a timeshare. But was not. But I also consult for the Vermont State Employees Association, which is one of the places where I've been in these bargaining sessions and being hit up about healthcare costs. But the Green Mountain Care report projected savings. I mean, we could work, it's hard without having the underlying data to actually work out exactly the size of the savings, but they brought out a plan that would have saved money overall. Less would have been spent on healthcare. They would have eliminated a lot of the costs of running insurance companies, which is big money. Saved some money on healthcare activities themselves, and they have a progressive financing plan so that the great majority of people, using their numbers, about 90% of Vermonters would have saved money. So there's no economic basis to move for Governor Shumlin's decision. They're doing it. Oh, yes, NESRI, National Economic and Social Rights Institute, has put out a plan based on the Green Mountain Care Board's plan, a better plan, a more progressive plan than what the governor came out with. But, it could be done, and there are people still pushing for it to be done in Vermont. There's no economic basis for Governor Shumlin's decision to back away from single payer. He did it because of political considerations. That's the residual category. I remove economics, so it must be politics. I'm not going to speculate about, what went on. I'm not that buoyant to the legislature there. I'm an economist. I'm not going to talk about it. But the economics from the report supported going ahead with implementing single payer in Vermont.
Larry?
Access. There's this assumption that if you give people better plastic, that they go to primary care docs. But there isn't a lot of capacity, extra capacity in the world. It didn't really work that well in Massachusetts. I'm an emergency physician. We saw more people when they got better plastic because they didn't have to pay as much to go to the ER. Where is the capacity?
First place it's going to come from, which did not happen in Massachusetts because Romney Care was Obamacare within the insurance industry. The first place is the hours every week that physicians spend processing paper for the insurance industry. A second place, very secondary, because we're talking about hours, as much as 10% of a primary care doctor's time is spent working for the insurance industry, processing paper, defending care decisions, etc. More than 10% of the frustration of primary care doctors, in my experience, I have friends who are doctors, more than 10% of their frustration. Surveys, a recent paper by Himmelstein and Wilhandler, one of many great works by them, shows that one of the major reasons people leave medicine is because of the frustration. So I would hope that we'll get some more doctors, people coming out of retirement. My family physician, as of January 1st, no longer practices because of frustrations with electronic medical records and hassles with insurance. They just said, hell with it. He works now as an administrator in a hospital part-time. Retired a couple years early. It's fine. Okay. Also, I hate to say this, but it's something that will happen. Doctors will move to New York. Also, there'll be more doctors will be expanding their use of nurse practitioners, et cetera, too. So I think the capacity, we're talking about an increase of 10%. The hours alone that doctors will save will be half of that. So I think we'll fill in the rest. You're absolutely right about the emergency room. That's been shown in the Medicaid study in Oregon as well.
How many jobs will be lost as a result of the insurance industry?
Well, if every job in insurance, in the insurance industry in New York, if health insurance industry went away, I believe that's 28,000 jobs. They won't all go away because some of those jobs are processing insurance claims from out of state. And there'll be jobs lost in Connecticut and New Jersey, which just makes me grin. But yeah, that would be 28,000 as an upper bound. Keep in mind also that these are, by and large, these are bad jobs. And I say that on the basis of low salaries and the fact that there's 6% turnover every month. People don't like these jobs. They'll get 2 years of unemployment insurance and retraining, at the end of which, virtually, based on experience with the UI system, virtually all of them will have new jobs. And a lot of them will be better jobs. Right. I mean, the economy is going to be expanding. We're going to be adding 200,000 jobs outside of healthcare, plus 50,000 inside healthcare, so it's going to more than make up for the jobs lost.
Who determines what services are covered in this system? And what doctors are paid for it?
Well, doctors will be paid on the current private health insurance rates, which are higher than Medicare and much higher than Medicaid currently pays. Services that will be included, I honestly can't answer that very well. All medically necessary. At some point, will there be a board, or somebody's going to decide whether my dental implant is medically necessary? There is a board that will be deciding these things. Yeah. But the definitions that I've heard about are very, very extensive. The major failing of the law is it doesn't yet cover long-term care. Okay, yeah. There's supposed to be in the law, or at least in Dick Gottfried's comments, it's in the law that in 2 years they're supposed to come out with a plan for long-term care. The money's there. We have $45 billion in savings. I have an estimate, which unfortunately I'd have to look on my computer again, of an upper bound for long-term care. It would be less than $45 billion, so we'd still be saving money. And long-term care, if you fund long-term care, you are saving New Yorkers money. Because whether they're paying for it out of pocket or they're paying for it in sweat equity, it's a money saving.
Mary?
Did your cost savings include the drop in auto insurance because they don't have to cover medicine, or the drop in workman's compensation?
Workman's compensation, yes. Auto insurance, no. Yeah. I mean, that's more savings, yeah.
Marty, you just mentioned that the doctor's fee would be essentially equal to the Medicare fee, which
Oh,
would be.
no, equal to private health insurance.
Private insurance, sorry. But you know what you didn't mention, or I missed it? What about the fee-for-service issue? You're gonna pay for all my echoes and all my CAT scans, or how's that gonna be handled?
It could be a fee-for-service system. People could establish capitation practices, I guess, but the basic model is fee-for-service. I think experience has shown that capitation models do not save money. The extra administration more than eats up any reduction in services, and the reduction in services is not necessarily a good idea. I would rather take the risk of my doctors over acting because they are inflating their incomes than the risk of a health insurance executive undertreating. But this is a live issue. The point, though, is that the capitation models, the experiments with ACOs under the ACA, the HMO experience, these are not money-saving.
The legislation does provide for, I guess the term is alternative payment mechanisms on an experimental basis and then implemented. It also provides for capitated care management essentially as a requirement that everybody choose either a PCP, a primary care practitioner, or a care manager as a vehicle for getting continuity of care, really, not as gatekeeping, explicitly not as gatekeeping. Bruce?
If you are creating the ability for people to access health care when they need it, the preventive in the front, as we know with providing better education as early as possible, I'm assuming then that part of the thinking is that it will lower the costs as well as increase.
Well, it eventually will. And also, on the train down, I just read a new study showing that people who gained access to Medicaid when they were children in the 1980s had higher rates of social mobility, higher rates of high school completion, college attendance. So there will be productivity gains long term. There are many studies showing that healthier people are more productive. And that will be, healthier people often engage in healthier health practices too. It's not just that bad health practices lead to bad health, but good health leads people to invest more in maintaining their good health.
In the 1980s, there was a movement towards having peer review where physician utilization of services was going to be reviewed by another doctor to see what was medically necessary. Is there anything like that planned?
Not in the bill.
Because initially it was a cost savings until it became different form of business.
Yeah, that's interesting. I don't know about that, but it's not in the bill.
I mean, how will this affect people with standard Medicare and their ability to get health care out of state?
Well, the New York Health Plan will have to be funding some of these activities out of state. Well, if it's in Medicare, then you'll still be able to access Medicare services outside the state just as you do now. Out of state, that's not going to change. Medicare is a federal program. Within state.
Who do I pay? Who do I pay?
Who will pay?
No, how do I pay? Medicare plus New York?
Well, Medicare Part B, one of the provisions in the bill, in the proposal here actually is Medicare Part B premiums will be paid by the state, by the New York Health Plan. So you won't be paying Part B premiums.
And Medigap policy?
Medigap policy, you won't need one in New York State.
But I'm traveling out of state.
Well, you may have to get one for out of state. You'd still have to be when you go out of state. But if you stay in New York State and you keep your doctors in New York State, then. Yeah.
One of the things we have to work out is what happens when New Yorkers move out, get sick out of state.
Your Medigap policy in Florida or whatever would be a lot cheaper because it would only.
I travel many states.
Okay, well, your Medigap policy outside New York State will be a lot cheaper because it won't be paying for anything in New York.
a lot of my patients who've retired, have moved to, who have private insurances, with a Medicare Advantage plan, have come back to see me yearly or bi-yearly because they're not covered in the states that they've moved under present insurance plans. You know, it's been going on for the last 40 years.
Yeah.
And you're first, then I.
Would there be any problem with getting the federal Medicare and Medicaid funds?
Well, the Medicaid it's a state plan, it's a state program. So, you know, basically how the state administers Medicare. Medicaid is up to the state. Medicare, my vision is the state will file, New York Health Plan will file as a Medicare Advantage plan that would enroll everybody, Medicare recipients, with no Medicare Part B premiums and better coverage so that you wouldn't need a Medigap plan in New York State, and full drug coverage. So you wouldn't be paying anything towards your Part D coverage. So I can't imagine why anybody wouldn't sign up for this state plan. But we cannot require people, Medicare is a federal program, we can't require people to join the New York State plan.
But it should be said, this does assume that the federal government will be cooperative in giving a
That was
waiver,
my question.
giving the federal,
How do we
depends
know?
on federal funds.
If the federal government would be cooperative?
I think it may depend a lot on the results of the 2016 presidential election. You know, I think one female candidate for president, I suspect would give all the necessary waivers to her, you know, new home state. The other candidate, whoever it is, I don't know. I'd go to him and say, look, you know, this is federalism. You Republicans want state rights, and you know, you want Alabama to be able to do all the terrible things it does. Well, let New York State do something good. So, I think we make a case. Sorry?
The alternative is that it could still be implemented, but it would be a wraparound. Like the federal program would exist, and then New York would wrap around that and provide everything else to New York Health, which is obviously not preferable, but it's not. It wouldn't be impossible.
Yeah, you'd still have two payers. You'd have Medicare and you'd have the New York Health Plan. Yeah.
Has any work been done on potential impacts to Social Security disability insurance? Like, could you project less disability later on with universal access?
I assume, yeah, universal, you know, many of these people die, many people don't die, they just, you know, have, you know, long-term disability, so, yeah, I imagine there would be savings on the disability program, yes. Yeah, more savings, thank you.
I think we have time for two more, yeah.
Okay,
Wait.
Okay. Since businesses would be paying 80%, what kind, if any, relationship would they have with the board who determines the services? Because I really want very much to be able to move out of a system in which an employer decides what kind of access I can have, what they would want to pay for.
I don't think employers would have any more say in the medical services provided than they would have about your retirement under Social Security. I mean, it's an assessment that the state mandates. It doesn't come with any leverage.
It's a tax.
Not a tax, it's an assessment. Yeah, your private health insurance premiums you're paying now, that's a lump sum tax.
Okay. A while back, I joined the Raging Grannies. And we would, then I broke a hip and so I'm still surviving. But created songs with familiar tunes and political content. So I did it, make it single payer. But then Obama came along and converted what's happening. So I rewrote it now. Obamacare is a business, and we are forced to shop with premiums and deductibles. This scam has got to stop. So make it single payer, no profits at this time. Trapped inside the market is really a social crime. We've been two more and that's it, short. We've been used, abused, ignored. The profits at the top, confused with health insurance. This scam has got to stop. So make it single payer, no profits at this time, trapped inside the market is really a social crime. Everybody,
Thank you all very much. Thank Jerry again.
Thank you for being the volunteer
Before
filmographer.
everybody runs out, on May 5th, we're going